All right, and thanks, Karen. Oh, I got that. All right, and thanks. Karen Dills will be recording this. So welcome everybody. This is the League of Women Voters, Chaffee County, and I'm Margie Gray, the member of the leadership team. And Karen Dills is going to be recording this, and Tara Merovka is going to be presenting the program. At the end of the program, and we'll have questions also, and we ask that if you have questions, to submit them in the chat box, and Karen Dills and I will be working on those to help Carol answer those. And if we don't have time to get your questions asked, I'm sure Carol will be glad to, and we'll help her get the questions and get them back to you. So we'll see what we can do. We'll also have some announcements at the end of the meeting about some exciting things happening with the League of Women Voters, Chaffee County. So stay tuned. All right. So Carol Merovka is a retired family practice doctor from New Mexico. She's lived in Salida about 3 years. Is that right now? 3 years, Carol?
Yeah.
And she jumped right in and got involved with the League of Women Voters, and we've just been so happy to have her as part of our leadership team. She's also serving as the secretary this year. So she's doing double duty, doing a program and this. So let me turn it over to Carol, and I ask all of you to please mute yourselves, and that you could welcome to have your faces on the screen if you like. All right, Carol?
Okay. First of all, I'd like to thank the leadership team for letting me do this presentation. Like many people that are in healthcare, healthcare and its situation is quite distressing to us. And although I'm retired, I still have a license in New Mexico. And for the last 2.5 years, I have been an advocate and a partner and a dear friend of mine and former patient in her journey through trying to get cared for lower back pain. And it's been quite an odyssey, to put it mildly. So I'm going to tell you a little bit about myself. As I said, I was in family medicine in Albuquerque, started out in private practice. Because of a personal change in my life, I started working with the New Mexico Department of Health, and I was the medical officer for the Division of Health Improvement. And that was a very interesting position because I worked with the regulatory part of CMS. Our division was the one that did all the complaint and the recertification investigations of home health care, hospice, long-term care, and our DD waiver program. And it was really eye-opening to me to be on the regulatory side versus, to be on the provider side. And then after I finished with the Department of Health, I went into a large geriatric group practice that ultimately got bought by a large national practice management. So I've been through a lot of changes in healthcare. And the one thing that I'm so intent on is that I feel that the American public is woefully not educated in the complexity of healthcare. Mm-hmm. And I'm hoping that we can make a case that if we get more educated, we can become better advocates, both for ourselves and for healthcare in general. So I'm going to open my PowerPoint, and I'm hoping like crazy this is going to work. Yeah, hold on just a second. I got to do one more thing. Okay, are we good?
Starting to, yes, I can see that now.
Okay, so PowerPoint's the way I rock, so I'm hoping that this is going to be okay. The first thing that I want to talk about is what the objectives were. Now, so why am I interested in this? As I said, I think that we do not understand how we got to where we are. And if we don't understand, I'm a big historian. If we don't understand how that works, then what happens is we just keep on churning and muddling. And I think it's important to know the history And then from there, we can figure out maybe how we could go forward. And I have some thoughts about how to go forward. And I think I would love to see us open a dialogue about what people think. We also need to understand why the healthcare costs are elevated in our country versus other developed countries. We're going to review the expenditures from 2019, and we're going to understand, I hope, the 4 profit centers of healthcare. I've included the League of Women Voters of the U.S. Healthcare Initiatives, which is in that wonderful program that they have that goes into many, many aspects of American life. When I was reviewing the web, I found this document and it's been very helpful for me. And then I'm going to talk about what consumers can do and what ways that we can go forward. So I think the most important thing to understand is that our healthcare system never was developed as a system. So we talk about healthcare systems, but it never was historically. It's always been terribly fragmented. And it also has seen an incredible increase in personnel and players over the 90 to 100 years that it's been in existence. So in the 1900s, when, virtually not many things could be done by physicians or hospitals, et cetera, there was about a half a person per one physician that was in healthcare. That was in 1900. And then in 1973, when there was a proliferation of many different ideas and thoughts, that went from 12 people to every one physician. And now it's much higher. Some people are estimating it's as high as 40. So that gives you an idea of how much explosion there's been in healthcare and also why it is so expensive. I think that was an amazing statistic to me when I found that. And it certainly speaks to why we have such a very, very expensive thing. The other thing that came is that the different fields of healthcare have gigantically increased. So now we have over 220 different professions that are involved in people's health. And the physician specialty, which has a lot to do with healthcare costs, has gone from about 10 in the 1920s to over 110 at this current time. And there have been lots of interventions historically to keep costs down. And in my opinion, they've been mostly ineffective. I have lived personally as a physician through a lot of these interventions and was involved in a project with Presbyterian Hospital, St. Joseph Hospital, and something that we called an Independent Practice Association in 1985. And the idea behind that was we were going to get the 2 hospital systems that were not in integrated care, which was Pres and St. Joe's. And we were going to start in a competitive environment with the University of New Mexico and Loveless Medical Center. That probably cemented for me the power struggles in healthcare. And ultimately what happened is that of those 3, we had a concept that we were going to be a stool with 3 legs, the doctors, the 2 healthcare systems. At the end of the process, there was one healthcare system. The doctors were absolutely cut down and disillusioned. And the other hospital system, unfortunately, went away, which was St. Joe's. So it's a system that a lot of people do not understand, and it's a Byzantine system. It just is not meeting people's needs, and it was never necessarily designed around the needs for patients, and it was never designed to hold down costs. I trained at the University of New Mexico and family medicine, and the whole intent of that family medicine program was to put the patient first. And we were taught that over and over again in every aspect of our training. And unfortunately, I feel that concept has been lost. So there's some things that I think are important in each one of these columns. So you can look at pre-1930. So what is a Flexner reform? The Flexner reform happened when a group of people got together from lots of different occupations. There were teachers, there were some physicians, there certainly were employers. And what they tried to do was that they tried to get rid of people who were not well trained and were not in the total scientific approach to medicine. So at that time, they got rid of practitioners, and the whole concept of physicians as the point of service really got started. It was also a time of organized medicine. I just got a book on the socialization of medicine from the doctor's point of view, and starting in 1930. I'm really interested in reading what this is going to be all about. We also started the rise of medical specialists. Basically, there were, the docs that were the family medicine people. Like they were the ones that were the that went through 4 years of medical school and then hung out their shingles. And then we developed internal medicine people. Then we developed the concept of pediatricians. And then we developed some concept of psychiatry. So those were the early primary care physicians. And at that same time, as you know, the country was in a major depression. And we started seeing healthcare costs rising because there's got to be a much more organized and complex system. And in the 1930s, we had the Blue Cross Blue Shield plans and the employer-based health care plans. And very importantly, Social Security was enacted. There was a change of discoveries where things like x-rays and other interventions were being discovered for care. And as a result, that just added on to another area of care. And then in the 1960s, we had basically, Medicare and Medicaid got passed through President Johnson's heart attack. If any of you read Joyce Goodwin, her book on LBJ, after he had his heart attack and nearly died, he came to realize, and he was also the president after Kennedy's assassination, he really came to realize that he had to do something as a legacy for himself and for the country in regard to social justice. And so Medicare and Medicaid came out of that. And this is the first time, and importantly, that we had for-profit hospital chains. Prior to this, it had mostly been hospitals that were charity-based and physicians that were fee-for-service. And again, we had a lot of rising healthcare costs because it had become much more complex, and there was no system to try to keep it under control. Kefauver-Harris drug amendments came into play during this time. That's an important aspect because it has to do with the patents for prescription medications, and Kefauver-Harris was the one that opened the gate for generics. So in 1970s, the United States started an attempt through the government of regulation and rate setting. Certificate of need was something that was started to try to keep the growth of hospitals and standalone psychiatric centers somewhat under control. So you had to have a certificate of need before you could build anything. When that went away, hospitals and freestanding psychiatry centers were able to build wherever they felt that there was a need, which also drove up the responsibility of people to get care, and also it drove up the fact that there was no competition for these facilities. I don't know how many of you people understand prospective payment and the DRGs, but the DRGs are diagnosis-related groups that have tried through CMS to control hospital costs. The other thing that happened in the 1970s, which had a big impact on my personal private practice, was the HMO Act. This was started in 1973. 1973. It was signed by President Nixon. And what it did is it started the financing through the government of HMOs, and the government did not own them, but it helped with some startup money to get HMOs enacted. HMOs were designed to keep healthcare costs down. That was the main reason that they were designated. And they came to us as physicians, and they talked about capitation, which meant that we would get paid a monthly amount depending on how many patients we had from their healthcare plans. They took the physician communities where they went in and had them join up with their HMOs. And if you didn't join up with their HMOs, their threat to you was that you were going to lose your patients, because the employers in your town were going to sign up with their HMO plan because it was less per month for the individuals covered. And in addition to that, they were going to take those patients away. So if you didn't sign up with them and take their capitation or their other forms of payment, then you would lose your practice. It was a big threat, and many people in my town of Albuquerque had a great deal of difficulty dealing with that. And we, as a little practice, suddenly started working with 5 or 6 managed health plans, whereas we had none before. And it was quite a change in how our life went. The other thing is that it was a big threat to the hospitals. If the hospitals didn't give pretty deep discounts, then what would happen is they would not get the patient. One of our hospitals, which was St. Joe's Northeast Heights, actually signs a really bad contract with FHP from California and almost went under because of that contract. The other thing that happened was ERISA. And ERISA, I gotta look at my notes because this is a long mouthful. It's the Employee Retirement Income and Security Act of 1974. And what it did is that it made employers become responsive and fiduciary for the healthcare pension plans and for the pension plans of their employees. And it was done because many employers were opting out of their retirement benefits because of the high cost of doing business. And so ERISA was supposed to be a safety net for employees. So going on now to the 1980s, we have a lot more competition. We have managed care. And because of the DRGs, which happened in 1970, a lot of the patient care was shifted from hospitals now to outpatient care. So DRGs give you a set amount of money for the diagnosis. So if you admit a patient with pneumonia, then that patient's care is under a DRG with CMS, and then the private insurance followed suit very quickly. So some hospitals were having to contract with as many as 300 to 3,000 different payment sources for their patients' care. And as a result, that has led to the very obscure pricing coming out of hospitals that we're going to talk about in a few minutes. The Hatch-Waxman Act was another act that changed things. And it basically, again, talked about the, I'm wrong. Let's back up a bit. The Hatch-Waxman Act was the generics. Kefauver-Harris was to prevent human experimentation on citizens of the United States. I'm sorry, I got those mixed up. And then I think all of us have, remember Hillary Clinton coming in and working with her husband in a role that many people thought was way above the First Lady's role. And she and many stakeholders came in and tried to hammer out the 1993 Clinton healthcare plan, which was presented to Congress and was never passed. In the 1990s, HMOs increased a lot. And so at some point in time, they were responsible for about 80 million lives in the United States for coverage. The relative value came to physicians from CMS. It is called the Resource-Based Relative Value Scale, and it's the one that says RVS. And let me tell you about this. This is very complicated, so I'm going to read it verbatim. It is physician payment system used by the Centers for Medicare Services. It's based on the physician's work, the practice expense, the professional liability insurance. It has a conversion factor, and it adjusts for geographic differences. And basically what happened is that if you were going to take care of a Medicare patient as a physician, it meant that you could not bill their indemnity plan or themselves for anything above what the CMS payment was. So for an example, somebody came in and wanted to do a 15-minute visit with a physician. So you would pay $35 to $40. Those are the good old days. And the CMS would allow $35, and either the patient would pay the extra $5 or their indemnity plan would pay the extra $5. And ultimately, it went away that if you were going to take a Medicare patient, you could not charge anybody, including them or another healthcare plan, for that visit or for that service or whatever the interaction was. The Stark Act was really interesting. If nothing else, those of us in healthcare can figure out any way that we want around something. So if the physicians, for example, I'm going to use physicians because that's where my hat is. If physicians wanted to increase their income because it was being cut by many, many other different systems, what they would do is, for example, if you were a surgeon, you would go in with a group of other surgeons and probably some other forms of financing, and you would build an outpatient surgery center. And that outpatient surgery center would then be where your patients went. Well, that's a conflict of interest, obviously. If you want to do a surgery on a patient and you send it to your surgery center, then you were benefiting from that, not only from the fee that you were getting, but also because of the profit from that surgery center. And most of these centers were for profit. The other thing, I mean, there's a lot of different ways that you could do this, but you could also do it with radiology equipment, lab, and so on and so forth. So the Stark Act was the act that prevented physicians or people financing a system that they were going to benefit from beyond fee-for-service. Then physician practice management started, and that was basically my last model of practicing, is that we had a physician, we had a bunch of us that were doing long-term care, skilled care, hospice, and geriatrics, and then we were bought out by a physician practice management company, which again, just adds another layer. So I hope you get the idea that as we've progressed from the 1900s to where we are now, all we've done is kind of gnaw on the edges. We've done a lot of different things that hasn't worked. And the reason it hasn't worked is because it is so damn complicated. I'm going to go a little bit into the Affordable Care Act. The Affordable Care Act, as you know, has been called Obamacare and a lot of other things, but it tried to take care of some of the major holes in the healthcare financing system. And basically what it did is that it, first of all, gave access to people financially that could not afford premiums or did not have an employer and weren't covered by Medicare or Medicaid. The other thing that it did is that it started protecting consumers or patients. One of the things that healthcare plans did, which is one of the most unethical parts of healthcare plans, was that they would not provide coverage to people who were ill. So if something happened and you got into a higher price for your medical care. You would be dropped, or you would not even get medical care because of a pre-existing condition. And that is really one of the things that the ACA did that I think was very, very important. As you know, again, it's been whittled down, but it still has maintained some of its integrity. And it certainly did decrease the uninsured in the United States. And I think we could do a whole talk on the Affordable Care Plan. So one of the things that patients are called are consumers. And the idea of consumerism has sort of taken off in the last 10, 15 years. And one of the things I think is that it tries to make a partnership between a physician and a patient. But one of the biggest problems in our healthcare system is that we do not in healthcare operate in a market economy. We don't shop around for the best prices. We don't save up for something and then go in and buy it in healthcare. We act on preventative healthcare, wellness, and we also act on acute medical needs. So if you need to go to a hospital and you have a broken arm, you can't shop around for a couple of days to go in and have that broken arm looked at. And you have a variety of places you can get that broken arm looked at, some of which are very expensive and some of which are not. But you really don't have a market economy in healthcare, and you never did. And that is one of the business aspects and one of the economy aspects that I, as a physician, have been trying to understand, because basically, healthcare, I think, has two major sides: the business side and then the delivery side. And one of our problems, I feel, is that we have not meshed those two sides. We have kind of a we versus us and so on and so forth. And to me, it's been an incredible experience getting ready for this talk, because, man, I have really gotten a whole lot of information about the business economic part of healthcare. And I think every one of us needs to know more about it. But again, it's very obtuse, and it's kept in a little basket, hidden somewhere in a dark corner. And I think we need to shine a light on that. And because we basically, as consumers, it's so uncoordinated. We've got state levels, city levels, county levels. The bargaining power to drive down prices is virtually lost in this system that we have developed. So how big is our system? Well, it's big. Right now, the national health expenses for our country in 2019, and remember, COVID really, happened around where a lot of people were hospitalized around March and May of 2019, and then has been, quite rampant during 2020. But the national health expenditure grew 4.6% to $3.8 trillion. That just staggers me. And what that translates is to $11,582 that we, shell out for healthcare per person in our country. Now that statistic is a little bit mystifying to me, and I was unable to really kind of ratchet it down. I don't know if that is based on the population. So if you're 1 year old, it's 11,582, or if this is for people over 18. So I'm going to give you that caveat. I don't know exactly how that per person was formulated, but I do know that it represents 17.7% of the gross domestic product. So many of us that are sitting here today are on Medicare, maybe all of us. Some of us have had a joint replacement. I was just at an orthopedic conference because I'm keeping my license in New Mexico. And one of the orthopedic doctors staggered me when he said that joint replacement in the United States right now is responsible for 1.5% of the gross domestic product. That's a lot of money for joint replacements. So you hear over and over again, we have a healthcare system that is twice as expensive as any other country, which is not true. And we still have bad outcomes, which is true. So when you look at the US healthcare system, right, this is in 2017, because this is the most recent ones that I could find. It was 10,224 per individual. So if you look over here, so it was 17.7% in 2019, and in 2017, it was 10,224. So you'd see it's going up. But the important thing is that when you look at comparative country averages, we're about twice of what most countries have as a healthcare expenditure per individual. So no matter how you look at it, we still are higher than any other country in the world. And we're still about twice as high in most developed countries. So those of us who are in Medicare, there's a projection from the budget department that in 2024, our coffers are going to be empty for Medicare expenditures on hospitals. Now, I'm sure there's going to be some dramatic changes in the budget, but that's very sobering. And that's a pretty solid statistic. So Medicare spending has been growing, mostly because of this complexity of our system, even though CMS has tried its best to keep costs down. And now it represents 21% of the national health expenditure. Under Obama's plan, the Affordable Care Act, states have the option to expand their Medicaid. My state, my old state of New Mexico did. Colorado did. Oklahoma, where I lived for 3 years, did not. So the states kind of decided, based a lot on their antipathy for government, if they were going to expand Medicaid. But now Medicaid currently in 2019 represents 16% of the national health expenditures. Private health insurance, as you would expect, grew. But the thing that is really important to look at is the hospital expenditures. They grew to $192 billion, which is a lot of money. Physician and clinical services expanded to about $772 billion. And then prescription drugs increased quite a bit to about $370 billion. So you kind of get an idea where all this money is going. And where all this money is going, basically, has for-profit centers. And as a result, until we figure out how we're going to cut down the profit margin, we're going to continue to have healthcare spending out of control. The largest shares were with the federal government, private households, and so on and so forth, and local governments and states through Medicaid primarily are part of the budget. So very briefly, just look at this slide. It gives you an idea where the money came from. So health insurance, that was private, was 73%, government public activities, and so on and so forth. So we have basically private health insurance, third-party players, and then we've got Medicaid and Medicare and private insurance. So that's what the pie kind of looked like. And then where did it go? So it went to physicians and clinical services, hospital care, prescription drugs, dental, and so on and so forth. In the other, home health care and health residential personal care, which is increasing as you would expect simply because we have an aging population. So I'd like to talk a little bit about why we have high health costs. In the United States, again, when you look at it from the business economic model, the biggest amount of healthcare spending is for labor and materials, which translates down to technology and specialization. So the more we specialize, the more we have a disease process managed by a bunch of different entities. So if you have, example, diabetes, you could have a primary care physician, you could have a endocrinologist, you could have a cardiologist, and you could have an orthopedic surgeon. So those are all things that could be involved. The more we pay for labor of the healthcare profession and the technology that supports it, the more we drive up costs. The United States has been very reluctant to regulate prices, except along the lines of Medicare and Medicaid. But there's been a lot of backlash, both from consumers or patients and from providers on any kind of regulation. And in our current political atmosphere, you can see the battles that are happening in Congress right now for the infrastructure. If you can, I can't imagine the blood that's going to be let when people start trying to do Medicare for all, or national health insurance, which people are talking about. Those are the buzzwords right now. If you think the infrastructure was hard, I'm just going to predict that gets to healthcare. And the other thing that has happened with healthcare is that we have this proliferation of middlemen and people that don't finance it and don't provide it, and yet benefit tremendously from the administration of it. We'll talk about that in a little bit. And I'm gonna make a pitch right now that every citizen in the United States, whether you're a kid or an adult or a retiree, that our health habits or lack of health habits are one of the major drivers of high healthcare costs in the United States. I almost practiced for a year in New Zealand. I wanted to see that amazingly beautiful country. And I had some colleagues in New Mexico that had done that in New Zealand. And I asked them, what was it like to practice in a basically national healthcare system? And without a doubt, they said overwhelmingly, one is that their citizens are expected to keep themselves healthy and not use the healthcare system. That is a community-driven cultural aspect, because what they do is that they keep themselves healthy. They're not going to use the national healthcare plan, and they're going to continue to afford it and to continue to use it. The second thing is that all of this technology that the United States does, which we are the leader. I mean, we are absolutely the leader in innovation. All that technology comes with a very, very high price. In New Zealand, they don't do heart transplants, and they do very, very few coronary artery bypass grafts, which helps reestablish the circulation of the heart. They just don't do it. You're expected to keep your diet right, to keep exercising. And if you develop congestive heart failure for whatever reason, they treat you with medications. And they don't hospitalize you at end of care. They put you on hospice. So it has to do with how the culture of the country. And I think we put way too little emphasis on the culture of our country in regard to wellness and our responsibility for health. And I think that we've really got to start working there if we're gonna, we have to take some responsibility, I feel, for our own initiation of these high costs. And one quote that I had is at the end of this slide, and it says, healthcare demand has no natural limit in the United States. Our society will always keep creating new treatments to cure previously incurable problems. So as a society, when and if are we going to accept that not everything is going to be saved or treated? And that is one of the biggest conundrums that I think we're going to be facing in the next 5-10 years and how we figure out a way to contain costs. The other thing that I think is very important to ponder is that I know myself personally that my 401 or my SEP IRA or my investments are held in healthcare companies. And so if this all goes away, what's going to happen to my investment? And that is my conundrum. Should I be doing this? Should I be looking at another form of mutual fund? I've personally already made the decision that I don't have any investments in coal or gas or the fossil fuels. I made that decision, but I haven't made the decision for healthcare because it's so lucrative. So I'm sitting here thinking, I need to probably make some kind of a guess of what I'm going to be doing. And the other thing is that 14% of the US employment is in healthcare. It's higher than manufacturing and retail. That figure absolutely astonished me. I knew it was high, but I did not know that so much of it was in healthcare. And it is a driver of employment, and it is a driver in the gross domestic product. So as one doctor said, well, if you're going to attempt to control healthcare, gore somebody's ox, and it's going to invite a very strong pushback. And I'm telling you, there's going to be a pushback from the American Medical Association, the American Hospital Association, the pharmaceutical lobbyists, the healthcare plans, hospitals. It's going to be quite impressive when this starts rocking through Congress in regard to people not wanting to have any changes. The other thing is that I really honestly think that the healthcare industry is very smart. I mean, we're not stupid people, and we are not people that are particularly lackadaisical. And we certainly aren't people that are lazy. And so anything that's been tried in regulation, it may have worked for maybe a year, but then the healthcare industry figured out a way around it. And we have a very, very robust lobbying effort against any kind of change. This is a wonderful book, and I have just probably done copyright infringement, but this is a book called The U.S. Healthcare Ecosystem. I would recommend it for anybody, although it's about, 1,400 pages that I've gone through in the last couple of weeks. But he has done a graphic of the complexity of healthcare in the United States. It's quite a graphic. I mean, you can't read it. I don't want you to read it, but I want you to understand that it is one incredibly complicated system. And so where do you start moving things? You can squeeze one area of a balloon and then it just pops out another area. And that is pretty much how healthcare is. You can squeeze down one, but then something else pops up that's going to replace it. There are for-profit centers, however, and these are quite important to understand as a consumer. Physician organizations, hospitals, the pharmaceutical industry, and health plans. They are the major sources of for-profit systems in the United States. So let's look at its organization. When you look at how you get something done, if you're a hospital, you have to have a physician's order to get admitted. You have to have a physician's order to have medications. You have to have a physician's order to have a x-ray. You have to have a physician's order for this, that, and the other. Once you get into a physician's office, then you also are directed with your care by the physician. So 85 or 90% of healthcare spending is directly or indirectly done by physicians. As I mentioned to you, in the 19th century, there was a big movement to improve the quality of healthcare and weed out the unregulated practitioners. When that happened, there was a collaboration between states. So right now, states are the ones that license physicians. So when you have that kind of an organization, it's very difficult to affect, physicians' activity when it's very fragmented and very state-based. And so that's kind of a sort of a difficult concept to understand, but when you're organized where you practice in a state and that state has its own set of rules and regulations, it very much affects how much or how little a physician basically can make in their practice. And another thing that we have to look at when we look at healthcare reform is how we educate our providers. Currently, the United States has the most extensive and expensive education in the world by many, many factors. We go to medical school after we've done usually 3 to 4 years of undergraduate. And then after medical school, we go into residencies. And that can be anywhere from 2 to 7 years. And after all that process of those 4 years of medical school, the median debt for a student is $200,000, which very much affects staying in primary care, going to rural towns and counties to practice medicine, and so on and so forth. It also very much drives up the drive for physicians to choose a specialty instead of primary care. And now, historically, and even for the most part now, physicians are used to fee-for-service. And that loss of fee-for-service has scared physicians to the point where they will not engage in healthcare reform. Now, that's not everybody, but I think that's a pretty global statement that's correct. HMOs were very negatively received by physicians. And so now we've got the idea that any monkeying around with fee-for-service is not going to be acceptable. And we've got to change that attitude in order for us to be partners in this process. The other thing that we're going to have to look at very strongly after COVID-19, because it was already creeping in pretty strongly before COVID, is the physician burnout and the healthcare providers burnout. And I'm saying physician, but I want you all to recognize that everybody in healthcare, especially the nurses, I have such a respect for the nurses. I get a little cry when I think of what they've had to do to care for people in COVID. It's been quite remarkable. So right now, there are many people, both in the healthcare area and also in the economic business area, that are really worried about the lack of primary care physicians in the United States. Because the COVID-19 pandemic has caused a very high rate of retirement and a very high rate of lost private practices and physicians. So, it's going to be something that we're going to have to deal with in the next 50 years or so, because it takes a long time to get somebody into the practicing seat. The other thing about physicians that we are very adverse. We don't like risk, which means we don't like lawsuits. We do not like malpractice lawsuits. We don't like them in any way that you can possibly think of. It's a financial thing, but not nearly as much as it is a mental health thing. Physicians who get sued for malpractice have a huge amount of mental health issues. Not all of them, but a lot. One of my colleagues in Albuquerque got sued as a plastic surgeon, and it affected him so negatively that he left practice and started started a counseling service for physicians in the Albuquerque area who had been sued. And he had, that was his reaction to his experience with the lawsuit. The other thing is that physicians are resistant to following practice guidelines. If we follow practice guidelines better, we could really, whittle down on the cost of healthcare. But again, across the board, when they'd done a lot of studies, when the practice guidelines were first instituted, which was in about 1999, 2001, physicians just, they just kept on merrily going down the road that they were in, even though what they were doing had been shown not to have the effectiveness that you wanted. And I think another thing that I find quite interesting is that very few physicians are in healthcare leadership roles, and very few physicians understand the business part of it. They understand it from their little cog of their practice, but they really don't understand the business part of it as well as they should. And because of that, they're resistant to any kind of direction by, their healthcare plan or that they're participating in, or the hospital that they're admitting patients to, and so on and so forth. This last bullet here says a lot about our profession. When there physicians in it was a large populace of physicians that were surveyed, only 36% of them felt that they had a major responsibility for decreasing healthcare costs. And they felt that other parties should shoulder the responsibility more than them, such as trial lawyers. 60% of them felt trial lawyers should do more. 59% thought that the health plan should. 56, so on and so forth. You can read this. That's a very telling survey. For a while in Albuquerque, I was president of the medical society, and I did a bunch of other stuff. And I really found physicians pretty hard to deal with. They had their opinions, and they were pretty conservative, and they didn't want any change. And so I think this survey didn't surprise me much when I found it. So that's physicians. I hope you haven't felt I bashed physicians too much. But the next one that I think is very hard to get your hand around is hospitals. Hospitals are the biggest expenditure area of healthcare. A lot of money goes into healthcare. And for-profit hospitals are accountable to their shareholders. And those shareholders expect to have good returns on their investments. My St. Joseph Hospital, which is where I was born in Albuquerque, is where I had an outpatient practice in the old hospital. And I had a very strong affinity to St. Joseph Hospital. They got bought out by Ardent during this, the changeover with that stool I told you guys about. They got bought out by Ardent. And when that happened, I'm gonna tell you what happened. They got bought out by a very, very strong for-profit. Their CEO was told immediately that they were to get $2 million per month out of that hospital. And they did it by cutting tremendously staff. I happen to know this because I was skiing in Wolf Creek, fell and hurt my hip. And I had to go over to my orthopedic surgeon in Albuquerque. And at that time, I wasn't in private practice. I was working at the Department of Health. So my orthopedic surgeon said, "Say, Carol, aren't you working for the Department of Health?" And I said, "Yes." And he said, "I'm going to tell you what happened to one of my patients." So during this visit, he said, "Well, what happened is that I had a total hip done with a non-sterilized instrument pack." I said, "What?" And he said, "Yeah." And he said, "I'm not the only one." And so I went back and told Health Facility Licensing and Certification what he had told me, that he was doing a complaint. And so we went in and investigated. So that's how I found out that this for-profit hospital was trying to get that much money out of it. I also found out 3 other things. One is that the hospitalists were employed by Ardent. They're the ones that are providing hospital care. The emergency room was contracted with Ardent. And when we started going around and talking to them, they were very afraid to tell us anything that was happening in that system that they saw, and they knew what was happening because they knew that they would be fired, that they would lose their contract with the hospital. One brave female doctor sat down and told me exactly what she'd been seeing. And 1 week later, she was fired. So that kind of gives you an idea of all of the different conflicts of interest that can happen in a for-profit hospital. I'm running low. I want to not go over. I think you can basically see that one of the things with hospitals is that, and one of the complaints of people right now is that they are very much not knowing what they're going to be charged when they get their services. And so there is something that President Trump did in June of 2019. And he signed an executive order that basically said there's going to be a very, very systematic price transparency in health care systems, primarily in hospitals. And President Biden renewed that Transparency Act January the 1st of 2021. The American Hospital Association sued to block the new rule, and the federal judge rejected it. And so now, as of right now, hospitals have to let you know what they're going to charge you for their services before they do them. Or the No Surprises Act will go into effect January the 22nd. And that basically says that you cannot be billed after your ER services much later because of some quirk that the hospital has been able to find, that they can bill you anywhere from, $10,000 to $15,000 more than what you were expecting. That No Surprises Act is going to go a long way in preventing people from going into bankruptcy because of healthcare costs. So the pharmaceutical industry, what can you say about the pharmaceutical industry? It is an industry, and it's very, very, very lucrative. And basically, we have the HMOs as a responsible mover for getting the prescription drug package. So that started basically in the 1980s, and HMOs had a drug benefit, and then that drug benefit was followed by the third-party players, and then that was followed by Medicare and Medicaid. The other thing that happened in the pharmaceutical industry are blockbuster drugs. Okay, so what's a blockbuster drug? Well, certainly HIV treatment. The cocktail of drugs that people take for HIV. If you are interested, I mean, it's like about 1,000th less if you go into Africa. You can get those drugs so much less expensively, but we pay a lot of money in the United States. The other thing that happened was the pharmacy benefit managers. They became the middlemen of between the healthcare plans and the pharmacy and the employers. So basically, I really want you to understand a little bit about this, because this is something that is really, really important to understand and to figure out how we game the system. This is one of the most important things in this talk, is that there's something called the spread, and it refers to the practice by some, not all, pharmacy medication, pharmacy benefit managers, I had that wrong, pharmacy benefit managers, is that they go in and they get a price from the pharmacy of what they're going to charge for a drug. Let's say it's Synthroid for thyroid disease. So you go in, you get a 30-day supply of Synthroid, you pay a $10 copay, and the pharmacy has told the health plan, okay, we're going to charge you $10 for that. We're going to charge the health plan $10 for that medication. Okay, you got that? And then the person had a $10 copay. So basically right now, the healthcare plan is out no money at all. And here's what the spread is. How much do you think that the healthcare plan now bills the employer? It isn't $10. It can be up to $70, up to $100. It can be $20. That's the spread. And by that spread, the pharmacy costs have dramatically increased. And and apparently there's no regulation that prevents that from happening. That's an area that I think really, really needs to be regulated. And as you know, no surprise to you guys is that, you know, basically the lobbying for health plans is really very, very strong. So, Margie, I'm over. What do you want me to do? Should I continue for 5 minutes?
Yes, why don't you continue for your 5 minutes? That would be fine.
Okay,
I'd like to.
all right. So when you start looking at health plans, basically health insurance doesn't act like any other insurance plan. It is the primary mechanism for small and big expenses. It's no other insurance plan works like this. And so the real question is, should we have insurance plans? And I think that's what we're going to have to be really grappling with. The second thing has to do with us as consumers. When somebody else is paying for your bill, that somebody else is your employer or the government. There is less of an incentive for you to change your health behaviors because, you know, you're going to get cared for whatever's going on. It also really clouds your healthcare decisions, and you look at it as an entitlement. And I see that over and over again. I have people come into my office and say, okay, I've been sick for 48 hours and I want the most expensive antibiotic that they saw on the television. They had a viral infection, and I spent, you know, more than 10 minutes of that encounter explaining to them why they didn't need that expensive. But they said, Dr. Merovka, I have paid for this and you're going to give it to me. And so, you know, I lost that patient because I wasn't going to do it. But there's a lot of doctors who say, you know, the easiest way, the path is no resistance, go on and do it. We have an entitlement in our country that allows us to depend on a prescription drug, a medical procedure, or whatever, because we don't know how much it costs. We have no idea how much this system costs. And I will tell you that studies have shown that 14% of consumers, employees don't know their benefit package. They just don't know what a copay is, what out-of-pocket is, what medical savings account is, and so on and so forth. The other thing that drives up health plans are insurance brokers. Insurance brokers are individuals who come in to the employer and they, you know, they tell their health plans plan, and they have no incentive whatsoever to save the employer any money whatsoever. One of the things that has happened with these brokers is somebody got a conscience. That was one of the brokers. And he was so dismayed at a comment made by a man whose wife could no longer get her chemotherapy for her cancer, that he went back and repented. And he started the Health Rosetta organization. And it is an organization to try to bring back ethics to these insurance brokers. And basically, I think the health plan market is too complicated for anybody to deconstruct. So the question is do we start all over again? Since I'm a proud member of the League of Women Voters, I'd like you to read this. Basically, the League of Women Voters US believes that a basic level of quality health at an affordable cost should be available to all residents. And that says a lot, and it's going to take a lot to get there. Other US healthcare policies should include equitable distribution of services, efficient and economical delivery of care, advancement of medical research and technology, and a reasonable expenditure level for healthcare. I could not get into healthcare inequity on this talk. It's huge. We all know it's there, and the equity of it is very important. So I'd like to talk about some ways forward. So one of them is we just resign that this is a system we're going to have, and it outpaces income until it fails, and we rise something out of the ashes. I don't know what. Or we let it continue to grow as long as it's keeping somewhat in pace with real income, and we just kind of muck along. Or we figure better targeted strategies. And I think the better targeted strategies could start with some of these things that I have mentioned. In the for-profit centers, figuring out how you can make them have cost containment. We can count on little steps. We can nibble around the edges, or we can hope for the big one. And for many people, the big one is the single payer plan, the Medicare for all, the national health insurance. My opinion is that we could never, ever pull this one off until we do a real alignment of all of these players with the idea that we have an ethical, moral responsibility. So here's my pitch. The Swiss cheese model is the basis for many, many, many different models in the United States and internationally. It was started by James Reason. He wrote a book called Human Error. I would like to make, I'd like to make a pitch that every one of us in the United States starts looking at how we consume healthcare, how we deal with our personal wellness, and how we're going to enact the ethics of our country. And so when you look at the Swiss cheese model, if you guys will look way over to the left, it talks about latent failures at the managerial levels. This is the culture. This is the culture of business, the culture of healthcare, the culture of whatever system you want to put it on, the culture of Toyota making cars, the culture of the aviation industry not to have plane crashes. This has been applied universally in many, many places. But until we as citizens seriously start looking at our healthcare habits and the way that we interact with the healthcare system, we can't be like the doctors who think we make a very small imprint on the problem. We make a huge imprint on the problem. So that's what I'm going to start doing, is I'm going to start really looking at how everything I do with the healthcare system, I'm going to start shopping around. I'm going to start making all of my friends available to what I know. I've got a friend whose husband is going to go into the heart of the Rockies. He's paying full hospital costs for a very minor procedure. And I'm going to try to help her navigate that because they're paying out of pocket. So that's my pitch. Thanks for listening. I hope you learned something. I'm done. Oh, wait, there's one more slide. These are things that I think you might want to read. Can we put them somewhere, Margie?
Yes, I can put them we make them available on the website somehow.
Okay.
Maybe a little blurb at the bottom on the front page, I guess.
Yeah.
Karen and I'll figure out someplace to put it. Yeah, send it to me and we'll figure out where to put it.
Okay. If nothing else, every one of us should read the Chaffee County Community Health and Assessment and Health Improvement Plan. That was instituted from 2017 to 2021, and now they're doing another one. This is very interesting reading. And the biggest concern of people they did a huge survey, is access to providers. And then there's another one that's very interesting, and that's the hospital cost, price, and profit review for the state of Colorado. We have the 9th largest profit per patient treated in hospitals of any state. And Polis and the legislature is looking at that. That's their report. Okay, I'm done. Thanks for listening.
Thank you. And I think what we've done before is that when we put the video on our watch video site, there's a place that we can put this information about the bibliography that you've provided. Okay.
Okay.
I think let's take a few minutes to have you answer some questions. We had quite a few people ask questions. One of them was like, what can we do? And I think you've kind of covered that. Several people are saying thank you. Up here, there was one, go back and say, here was one, when you talk on the slide about how much of that $11,582 person covers actual healthcare costs, treatment versus insurance coverage, and all that may or not be used. Do you have any idea on that figure, if that includes the cost of like insurance?
No, that does not include insurance. That is just what is it. That's just what the healthcare delivery system generates. And as I said, I don't know if that's every citizen in the United States or what it is.
Okay. Somebody asked about how do these statistics of different healthcare professionals and specialists in the United States compared to other industrialized countries? So our system is now designed to make a profit for healthcare providers and hospitals, correct? What are your suggestions, solutions to bring healthcare costs down? And you've talked about that, but what do you know about comparing the United States? You had the cost, but do you know how many specialties and things are in other countries? You mentioned New Zealand and how their health culture is different than ours.
Well, I can tell you I did, because I'm so interested in the cost of joint replacements in the United States. I think there's, I had patients who never should have had a joint replaced. They were 85 years old, didn't move around, and they had a hip replaced. So there's some ethics in regard to that. But the average salary of orthopedic surgeons in the United States is about $415,000 per year. The average salary in the United Kingdom for an orthopedic surgeon is about $150,000 to $160,000, and in Canada it's the same. Now, we have very much higher salaries for physicians across the board in the United States. We have tremendously more healthcare hospital expenses than anywhere else in the organized, in developed countries. And that is part of the problem. And that's the part of the problem is that these stakeholders are going to push back like crazy when people start changing things. The Swiss cheese model is that you can't go to any one place. You have to go through a whole series of events that are going to impact what happens. So one of the things is, if we really start looking at medical education, do we really need to have 4 years of an undergraduate degree? Can we make some inroads into how much it costs so that we can get physicians that will move more into primary care into rural areas? So I think that's one of the questions. Do you think I answered that okay?
Yeah, I think that's, Karen, do you see another one we want to ask? And I'm thinking too that I've got a few announcements I can make, and then people can stay on and ask you some questions directly too. Karen, do you see a question?
Yeah, just one, a few things that have developed. Do you think that the broader use of physician's assistants, nurse practitioners, I'm adding telemedicine and artificial intelligence, might help reduce cost?
I do. I think all of those things. But I've worked with nurse practitioners and I've worked with PAs. My problem with them, and I'm being very honest, is they do not have enough clinical hands-on experience that we get during our medical training and our residencies. So they just don't see stuff. You know, it's not that they're very intelligent, they're very motivated, but they don't have the clinical expertise that physicians do. I think a lot of primary care can be handled very, very well by mid-levels. But when it gets to more complicated disease, that's what we're trained for. Practice guidelines, Karen, could do a tremendous amount to unnecessary care. I mean, if we could just follow practice guidelines, and that that's not AI, but you know, it's along the same concept.
Okay.
Yeah.
Thank you, Carol. And I'm
Yes,
going to ask
great
people to
job.
stay.
Great
Yes,
job.
very, very informative. It's like, I have so much to learn and you've covered so much. It's brought up many questions. Let me just take a minute and ask some, give some announcements for the league, and then we'll invite everybody to stay on and unmute yourselves, and you can ask Carol and talk some more with her. So our league is in the beginning of our second annual, our biannual fundraiser, the selling of poinsettias, and this year Christmas cactus has been added to it. The information is on our website, and so go there and look for it. It was also sent out in an email to you. And Ellen and Jean have worked hard. They've got a new supplier this year, and everything's going to be given out on a Saturday morning, so that should help. The plants will be delivered on a Thursday, so there's days for the plants to kind of get settled in and divided up, and then people will pick them up. I know they're going to need help on December 2nd to bring some plants from Leadville down. So if you've got a SUV or something that's heated, or a van that you can help them, please let Jean and Ellen know, or let me know about that also. So that's it. Our December meeting on the 13th, I think it is we're working on mental health, and Karen's been working on getting speakers for that. And is that all firmed up yet, Karen? Do you know?
No.
Okay, so that's our topic, that we're hoping to come up with mental health in Chaffee County and around the state. So that's our goal anyway for that. We are still working on having the county commissioners first part of the year, that we always invite them to come, and that we might even do that as an evening a presentation rather than at noon. They would have more time and we would have more time. We also are interested in several members were interested in immigration issues. And so if you have ideas for speakers or topics of how you would like to have that program presented, please get in touch with me or somebody else on the leadership team so we can work that out. Great Decisions, we co-sponsor that program with the Buena Vista Library. And I know Carol Sanford, who's one of our members and works with the library, she's taking orders for the books in advance now. If you choose to buy a book, they're at a discount now. If you buy them later, they're a little bit more expensive. This is with the Foreign Policy Association. And the Great Decision talks will begin, discussions will talk in January. If you didn't have the opportunity to see the Secretary of State and the County Clerk, Lori Mitchell, with our Great Decisions, Drinks and Dialogue last month, that video is on our website, so you can go there and watch it. It's very informative. The redistricting process is about finished. It's finished at the national level, and next week, the 15th, the state House and Senate districts will be approved by the Supreme Court, or they will make some changes. And Chaffee County is moving all around. We're going to be in different everything and with different people. Let's see, what else? Karen, can you think anything else you need to add in here? I guess not. All right. So thank you, and unmute yourself. And if you have questions you want to ask Carol, I know she'd be happy to answer some questions. And Karen, if you want to stop the recording, you can do that. And